Hello. Welcome. Thank you for coming and learning more about all of these. It's part of life. Of course, we had Scott sharing about funeral homes. We had the firefighters come in. Let's just be honest. We came because firefighters are really cool. Then I got to talk about funerals at church, and tonight we'll talk about something that's in a space kind of in between. Next week we have an attorney, and then the week after that, hospice care. So every week I've tried to think about where does the church intersect with this? And here's a scripture passage that came to mind. I came that you may have life and have it abundantly. That's something Jesus said. To me, that's a quality of life statement. And I think as people of faith, quality of life is really, really important to us. Not just, I want to stay alive as long as I possibly can. The thing is, those questions about quality of life are really difficult questions, and it's kind of hard to navigate, but I have such good news for you. There are people who come alongside us in those really difficult questions. And I'll introduce them in just a minute, but let's open with a word of prayer. The Lord be with you. Good and gracious God, we give you thanks for this time, for Laura and Sarah and the wisdom we're about to receive, for all the ways you show us to live abundantly and generously. In Jesus' name we pray. Amen. So we have Laura from the Palliative Care. Palliative is Palliative. And as Alan wisely said last week, what? That is the right lead-in. Laura's going to tell us all about palliative care and the unique space that it occupies in medicine. We also have Sarah, who's a social worker, who's going to tell us about the unique space. I think, if I were to guess, I think you are the most underutilized folks in medicine often, because everyone's like, oh, I know what a doctor does and I know what the nurse does, but here's this whole team that's there to help you have the quality of life that you want. And so I'm really excited for what they're going to share with us. So who's going to start, Laura or Sarah? Come up and pass it back and forth. And they made us cookies. Sorry, those of you at home, you'll have to make your own. But they made us cookies because it is all about quality of life.
You can't have quality of life without chocolate chip cookies. So, my name is Laura Waldock. I'm a nurse practitioner with the palliative medicine team over at Delnor. I'm also privileged at Kishwaukee. We're an interdisciplinary team. That means that there's physicians, there's 2 young physicians, there are 2 nurse practitioners, we have our own nurse, the chaplain's part of our team, and we have our own social worker, Sarah.
Yes.
So, we're just going to go through this PowerPoint. I like this little MasterCard looking thing on here, and it's true. We care about you. We care about your pets. The only other people in the hospital that are going to possibly ask you about your pets are the infectious disease doctors when they can't figure out what you have. So, but we are the quality of life people. And palliative and hospice, and there are some, I'd say, older physicians at the hospital who don't even know what palliative medicine is. We'll see a lot of times in the notes, consult palliative / hospice. We're 2 completely different things, We're a newer specialty, maybe within the last 30-ish years, Sarah. And so our patients, what we have in common with hospice is our patients have a life-limiting progressive illness that will eventually take their lives. We are also, what we have in common with hospice is we're about quality of life. The difference is that, and we also have multidisciplinary teams, like I told you. A hospice also has a chaplain and a social worker and physicians, nurse practitioners, nurses. The differences are our patients are continuing to seek treatments. They're continuing to come to the hospital. We are all about the quality of life. Both of our backgrounds actually are in oncology. I was an oncology nurse practitioner. I was medical oncology and I was gynae oncology as well. And so we have a very strong oncology background. I would say that maybe 70% of our patients,
I'd say a good number, yeah.
yeah, are oncology patients. But so our patients, they could have a stage 4 cancer, a stage 3 cancer, and they're undergoing treatments, and we follow them along. We help them with their symptom management. We have conversations with them. We support them every way we can. Hospice, our patients come to us. Our patients come to the hospital. We see patients in the hospital. We're consulted in the hospital. Our patients are also, they come to us in our clinics. We have outpatient clinics where they come to us. So I have a patient now that's in the hospital. Actually, I have two that are in the hospital that I know from my clinic, but now they're hospitalized, and we're that familiar face going in and talking to them. Now go ahead.
I think what we find in the work that we do is that because we get to see our patients in the clinic and then are there with them in the hospital, we're able to build that relationship and that rapport, which, as you know probably from visiting with other doctors, the people that you really get to know are the people that you trust. So walking along with people for this long time span when they're going through an illness is really important to the work that we do.
Can you tell them the differences with hospice then, how the medical care goes?
So having people come to us is important. When people start transitioning to more of a hospice plan of care, it's when they want to focus more on only their symptom management and being comfortable, being at home, not having to come to and from the hospital, not having to go and see their physicians anymore, not taking that time and that energy, because maybe it's taking a whole lot from them when they'd rather be spending that time with the people they love and doing the activities they love.
So I have down here a plot twist. Some people find it confusing because they'll say, well, I have palliative coming to my home. Hospice agencies also have a palliative arm to them, and that involves a palliative nurse practitioner that comes to the home, goes to the facility, wherever the patient is, about once a month. And they work with the primary care physician to give that care. So it's not as, we're a whole team when you use a palliative from a healthcare system, but when it's the hospice agency that has that palliative piece, it's a nurse practitioner that comes in once a week. So once a month, blah, blah, blah. So palliative medicine, you may hear palliative medicine, you may hear palliative care. It's on the next page. So once again, it's that late or end stage chronic, life-threatening progressive disease that will eventually take their life. So we see stage 4 cancers, we see stage 3 cancers. I've had stage 1 breast cancers or stage 1 or 2 head and neck cancers who, especially the head and neck cancers, we support them to get them through those treatments. Those are tough treatments. They're undergoing chemo and radiation. They're very difficult treatments. And so we'll support their symptoms going through it to get them through it. End-stage cardiac disease. We have heart failures, end-stage heart failures we see. You know, I have a heart failure patient. I have one in the hospital right now. I see her in the clinic maybe every 3 months, 4 months, just check in. We have conversations when we're there. I would say with my outpatient clinic, probably at least 30% of my time I spend with patients is socializing. So, because we really get to know them really well. They get to know us too. End-stage lung disease, COPD, pulmonary fibrosis, interstitial lung disease. We see a lot of those patients. Neurological disease, Parkinson's, end-stage Parkinson's. There's more, strokes, severe strokes. I have a new consult tomorrow for somebody who's had a severe stroke. GI disease, liver failure. We've seen more of those. We've seen a lot more of those, and I think it has something to do with COVID. I think there was a lot of drinking going on during COVID too. We're seeing a lot of young liver failures, really young. GU disease. So that's like urinary. Usually it's when patients decide, I'm done with dialysis, or they start thinking about it, that their quality of life is really being affected by dialysis. So then they start seeing us if they want to, and we talk to them, we help manage any symptoms that they're having, and then they can make the decision if they want to stop dialysis. Also infection. So I've done this before COVID too. And once COVID came along, and we didn't really have infection patients. We would have somebody would have a very large wound that was non-healing. But then COVID came along, and boy, our life was rocked. We were I don't know if you knew anybody that was in the hospital at the time during COVID, but there were no visitors at all. And we were the team that would be the contact with the families during COVID. We were the ones that made those phone calls, gave the updates. They're not doing well. We're going to have to place them on a ventilator. Do you want to place them on a ventilator? Explaining everything. Sometimes we would meet the families outside the hospital so we could see them in person, because those conversations are very difficult over the phone. We were the team dressed in all our garb, holding the iPads in ICU so the family members could see their loved one. It was a rough time. And we still see infections now to this day. Same thing. Not like it was. So I think we already talked about this. We're available at the hospital, available in the clinic as an outpatient. There's always one of us on call, one of us providers on call. I'm on call right now, so if you hear my phone go off, I'm not being rude. I'm on call till 7 tomorrow morning. My week is done then. This was my 11th day in the grow working. Tomorrow's my 12th day, and then I'm off for 2 days, 3. But so we always take calls. So if our patient's having uncontrolled pain, it's 3 in the morning. We want to keep them out of the ER if we can. First of all, you're going to wait for a long time. And we want them to be safe. And so they can call us when we're on call, and we'll tell them what to do. And if we can't manage it over the phone, then we may have to send them over to the ED. But we really try our best to keep them out of the hospital. Let's see. Flipping here. What we offer. Okay, symptom management to improve quality of life. So we try to look at the whole person. You go to the cardiologist and they look at your heart. You go to the lung doctor, they look at your lungs. We try to look at the whole person. The oncologist will look at your cancer. You're more than a disease, right? You're a human being. You have a spiritual side. You have a social side. You have a emotional side. Sorry, I don't mean to forget about you. You have an emotional side. You have your support system. We support the support system as well. So we support the caregivers, and we'll show you a few ways how we support the families a bit later on. Sarah will come with us. Sometimes it's just a provider. If we're checking up on symptoms, it's one of us nurse practitioners or one of the physicians. Sarah will come with us to new consults and go ahead.
I usually go with them to new consults because we like to normalize the role of a social worker. I think, as a history with social work, sometimes I guess we're given a bad rap, but we really are there to support. We fill in a lot of gaps. We're taught to pay attention to people's emotions as well as their interactions with their families. So when I go with one of the providers to a new consult and get to know the patient as well as their families, I'm helping to talk through things. I'm helping to analyze and say, I'm seeing that there's some strong emotion when we talk about this, what's going on for you, so we can delve a little bit further. Sometimes the providers go on their own for symptom management. Sometimes I see patients on my own for symptom management because we're talking about some of those feelings that come with a life-limiting illness, because there's a lot of emotions that people go through, as well as losses they may experience along the way that we process.
Sometimes the chaplain goes with us. Sometimes there's 3 of us walking in the room, the social worker, provider, and chaplain. Our nurse, when she knows them from outpatient, she'll go up and meet them as an inpatient, or if there's a new consult in the hospital that's going to be following with us then, our nurse will go up, introduce herself. I'm your point of contact. We talk every single day, every single morning for about 30 to 45 minutes. We all meet, our whole team, our whole interdisciplinary team, and we go through our whole list. And we talk about our patients. We talk about our inpatients. We talk about our outpatients. And because I see things differently than Sarah sees them, than our chaplain sees them, than our nurse sees them, or that one of the doctors sees them too. So I think that we give very holistic care.
By having those meetings every morning, especially with our hospital inpatients, we're able to notice what needs need to be met and maybe which team member is going to best meet those needs that day.
That's true. I do need to put these on. Wait, even as big as I made it. So our role is to ensure the patient and family are educated regarding their disease and the disease process. We support them. We support our patients no matter what decisions they make. We want to make sure they're fully educated, that they know all their options, and then we say we walk beside them. We support them. We don't walk in their shoes. And when patients are making really serious questions, do I have this, or do I not have this, or do I stop treatment, or what do I want to do, I always tell them, no matter what decisions you make are always 100% the right decisions, because they are your decisions. Nobody else walks in that person's shoes. You must have written this, because I've never seen this line before.
So that's basically what you said. Recognize the importance of the individual
Okay.
and support their choices.
Okay.
So when people are making decisions about care moving forward, what I think sometimes gets missed, especially maybe by people who are only focused on a certain organ, is that the person is a whole person, and they've lived their own life, and they have their own experiences, they have their own support system. All of that goes into whatever decision that they make. And we need to be aware of all those factors and support them in those factors, because they are an individual, and we're helping them to get the care that they want to get.
Mm-hmm. A lot of times when we go in the room, we'll first ask, what have the doctors told you? Dr. Saul was in today. What did she tell you? Because we always want to know. I can look in the doctor's note. I can call that other doctor and ask them what they told. But we want to know what the patient's perception is of what was said to them, because that's what we need to work off of. Other things we do, besides symptom management, we talk about what's called goals of care, and we'll get into that. We also will do advanced directives. We'll assist with advanced directives, and we'll also get into that as well. In terms of symptom management, we manage pain. Pain is probably our number one symptom that we manage. We manage pain that's associated with these end-stage diseases. I write a lot of prescriptions for opioids. We don't manage things like chronic back pain or spinal stenosis. We're not a pain clinic, but if the pain is associated with that disease, of course we'll manage it. We don't manage pain that's post-operative pain or acute new pain. I'll have patients now that'll be on a long-acting morphine, and every now and then need like a short-acting morphine for breakthrough pain, and then they'll call me and they have this terrible new pain, and I don't want to increase pain medication for that. That's new and that's different, and that needs to be seen and assessed. So, in that case, we would make sure that, we would contact the oncology office, or we would contact the primary care, or in some cases send them to the emergency room, depending on the other symptoms that they're having. So when we use pain medication, we don't go straight to opioids. Sometimes you need opioids, but there's other times that scheduled Tylenol works just as well. There's other times that a warm heating pad. There are other times that, actually, every now and then, I'll use aromatherapy in the hospital, because there's also something called existential pain too, which is where Sarah comes in as well. And existential pain can cause physical pain, cause you to feel physical pain. It can make any physical pain you're having feel worse too.
Existential pain is often the pain that's caused by all the emotions that are involved. Existential pain is often caused by all of the emotions that are involved with a serious illness. So sometimes your anxiety is going to increase how tense you are, which can help to increase the pain. And so sometimes we talk about with our patients that we feel like there's a lot of existential pain going on. So while Laura can often do prescriptions, sometimes it's doing additionally relaxation techniques or deep breathing techniques.
Something else with pain is you'll notice that we ask a lot of questions about pain. Does it move anywhere? What is it burning? Is it stabbing? Is it aching? Because we treat those different kinds of pain in different ways. There's a pain called neuropathic pain, and we don't give opioids for neuropathic pain. That doesn't make sense. It would just make you feel drugged out They wouldn't help that. So I've sent patients for acupuncture, actually, for some neuropathic pain, and it's been successful. So whatever works for them. There's I've had patients who've had good success with, what is that called, your hands? Reiki? Reiki, yeah. And I'm like, really? That works? But if it works for them, it works. So as long as they say it works, then it works. Bowels. We manage bowels because if we're prescribing opioids, a lot of times you need bowel management as well. Shortness of breath. So if you or anybody you know has like an end-stage COPD or emphysema, pulmonary fibrosis, you may notice that they've been prescribed or you've been prescribed an opioid, morphine, and that really does help ease that work of breathing, because the more you feel breathless, the more you can't breathe, because then you are anxious that you can't breathe, and it's a big vicious circle. And just a little bit of morphine can help relax, and the patient can breathe better. So we do breathing, fatigue and sleeping issues. We talk a lot about clean sleep, big melatonin fans. Palliative team, and anxiety and depression. So we'll prescribe, there's situational anxiety, situational depression. So I'll prescribe, some medications, Lexapro or any one of the depression medications, depending on the situation. When it gets to the point where that's not working and then there's another one that's not working, then we'll turn it over more to a psychiatrist. But situational anxiety, situational depression, that's usually expected with somebody with this life-limiting disease, this disease that's threatening their lives. And then we have Sarah. Goals of care. So these are these conversations that we have. This is why palliative works the best when it's outpatient and inpatient. These are conversations that we have. Initially, I'm not going to walk into a patient's room and say, hi, I'm Laura from Palliative. What are your symptoms? And let's talk about your goals of care, because that means nothing. It's getting to know the person. It's getting to know their W's, their wishes. What do they wish for? What do they worry about? And how can we work with the rest of the health team to make sure that we're always meeting their wishes and worries? When I have these conversations, they're like I said, my follow-ups are 45 minutes long. My new consults are an hour long. And most of that time is social. They know about my life. I know about their lives. And these are longitudinal relationships. They go on and on. I just had a patient. I have known her I met her in the beginning of her diagnosis, and I've known her for 2.5 years. And we would have these conversations bit by bit. I'd see her every few months, and she was on a little bit of pain medication, but not much. And, then there would be a new chemo, and then there would be a new chemo, and we just kept meeting. And, our conversations originally started, where were you born? Like that. By the time we got into year 1, she was telling me her fears with her daughter, that her daughter was going to be alone. They only had each other in the world. And, these conversations just became naturally more and more deep, would you say? Yeah. And then she was with me in clinic one day, and her daughter came in with her, and she was pushing her in a wheelchair, which was, she would never be in a wheelchair. I know her. By this point, I know her. She must feel really lousy to be in a wheelchair. And I ended up sending her to the emergency room, and she was admitted. And I went to see her the next day, and she asked me if she was dying. And actually, I did tell her I didn't think at the moment. But I was off that weekend then, and she was like getting ready to go home, and then she took a turn for the worse. And then I went back in, and she said, I think I'm dying. I said, I think you're right now. I think you're right. And she said, is this the end? I said, yeah. This is, I said, yeah, this is the end. I thought, I think we should call your daughter to come in. So we have some really serious conversations. A lot of people ask, how do you do your job? Aren't you depressed all the time? And I would say, no. I mean, my God, I'm honored. I'm so honored to be, sorry, I know I keep talking. I'm just absolutely honored to be in somebody's life, and I helped make her feel better for 2.5 years too. You know, she had good quality of life. She had great quality of life, and so.
It's not unusual for Laura to keep talking and me not to be able to jump in, just so you know. But I have to agree, it's a calling and it is an honor. It's an honor to be entrusted and brought into people's lives to have these deep conversations and get to know these people who have had these wonderful lives and learn and just be present with them.
And when they're hospitalized, if you've ever been in the hospital before, there's 50 new faces that walk in your room every day. And they know us. And so we're that familiar face. Okay. Onward, forward, goals of care. So I hate reading from PowerPoints, but I'm gonna read this because I think this is evidence-based medicine. That means that it's been proven that this is the right thing to do. This is the best thing for patients. Active discussion about an individual's goals and preferences, specifically as they relate to end-of-life issues, is linked with reductions in hospital utilization and aggressiveness of care at the end of life, increased use of hospice services, decreased family conflict, a greater likelihood of receiving the care that they want, and dying in one's preferred place of death. Studies in adults have shown that patients with life-limiting illnesses want their clinicians to initiate discussions about prognosis and goals of care. There are many times we'll walk in a room and the oncologist says, anyone says, any doctor says,
Don't have a crystal ball.
yeah. No, I was going with just go to rehab. Just go to rehab and get stronger for 2 or 3 weeks. Go to subacute rehab and get stronger. When that patient, we know, has like 6 to 8 weeks left to live. And so we're having these conversations. You have, just to make sure that they understand that if you have 6, 8, 12 weeks left to live, do you want to spend 2 or 3 of those weeks at rehab, at a nursing home? So a lot of times we're the team that talks to them about that and tells them that because they need to be able to make the decisions that they want. So, advanced directives. All yours, baby.
Thanks. So one of our roles in the hospital is to support the teams in ensuring that if patients want advanced directives completed, that they are completed. In your packet tonight, we put 2 of the ones that we often assist with in the hospital, one being the healthcare power of attorney form. That's a state of Illinois form. They're both state of Illinois forms. With the healthcare power of attorney form, it's not something that you have to have a lawyer assist with. It's something that the chaplain or the social work team can assist with in the hospital. The question that it's really asking is, if you're in a state where you can no longer make healthcare decisions for yourself, who do you trust to make healthcare decisions for you? And what I typically ask people to think about when they're making that decision is it doesn't have to be your closest kin, it doesn't have to be your oldest child, it needs to be a person who you trust to make the decisions that you would make for yourself. And sometimes that's kind of surprising to us, who we would think would make those best decisions for us. So it's something to think about and not just put someone down. The healthcare power of attorney form is a document, but we encourage that you have ongoing conversations with the person you want to make decisions for you. And the reason we encourage that is because we don't know when something may happen, car accident being kind of a big one that could happen to any of us at any time, where we might have to tap that power of attorney and say, what would they like in this situation? What do you think we should do? And it's only for medical decisions. That's all it's for.
The financial one's a legal piece. That an attorney has to do the financial one.
The other form that we've provided for you is called the Provider Order for Life-Sustaining Treatment. Until a few months ago, it also required a witness, so I was pretty involved. Doesn't require a witness anymore, it only requires your provider. This document is what you might hear as a DNR form, a do not resuscitate form. It is a discussion and order between a provider and their patient to determine if the person would want to have resuscitative measures or not. And then other, why can't I come up with it? The three sections down below which say what kind of treatment you would want if your heart had not completely stopped or you hadn't stopped breathing. What type of interventions? Thank you.
So the first one is like full everything. You want those ambulance sirens going. You want everything possible done. Intubation, going to what we call an LTAC, a long-term acute facility to stay on a ventilator. The first one is aggressive care. The second one, I think it's called selective interventions, and that is like BiPAP. So BiPAP is this big mask. It's kind of like an external ventilation that they can put on your face. You can't really talk with it. You can't eat with it. Some people have it on temporarily just to try to get an oxygen level up or to get some of that CO2 off of you. And then the bottom part is comfort. So that means, if you break your leg, are they going to take you to the hospital? Absolutely. That means that they're not going to intubate you, put that breathing tube down you, put you on a ventilator. I can't remember off the top of my head what else is on there. But there's also a space under there that you can put specifically what you want and what you don't want.
It's basically a guide for if you can't speak for yourself. That's one of the reasons that we have the form. When you're in the hospital, a doctor or nurse practitioner will ask you if you want to have resuscitation or not. And if you elect for a DNR, they put a band on your arm that notifies that notifies the team. However, that purple band does not follow you outside of the hospital, which is one of the reasons we talk about this form, because some people want that order to follow them outside of the hospital. So if they want to, we fill it out with them, and we talk about putting it either on the refrigerator or in the freezer, because that's where emergency personnel may look for it.
They'll often ask when they get to your house, do you have anything for me on your refrigerator or in your refrigerator? That's where a lot of people keep them. There's one section, and there really all that needs to be filled out in that, there needs to be the signature from the provider and from the person who's filling it, who the DNR's for, and it has to your name up there, and then the DNR or full code checked on top. There's also a section about feeding tube, and that's optional. It's advisory. I would say a lot of patients that are making themselves DNR say, I never want a feeding tube too. So, but that's totally up to whoever's filling it out.
Yep. So the next thing that we'd like to talk about a bit is something that I've started, which is called a legacy project. We noticed a need with some of our patients to develop a relationship between their families and themselves, the legacy they may leave when they die or pass on. And do you want to?
Well, I was going to say it started because we had this young patient.
It did start. We had a young patient.
Really,
you know
like mid-20s, and he was dying, and he had these little kids, and he never went to hospice. We took care of him in the hospital. He's in his mid-20s. He doesn't have to go to hospice. It was a really rough situation for the whole hospital. Actually felt this, and we're like, well, what can we do? We want to, some sort of memory for his kids. And, I finally got him to agree. I said, can we do your handprint and then your kids can hold your hand at home? And so we were trying hard to think how we could do this. First, we go down to New Life where the babies are born, because they stamp their feet. And we're like, can we have a stamp pad? And they're like, what do you need that for? And we told them, and they're like, here, take the whole box. And so first we put that all over my hands. These it doesn't come off. I was like using these things that you're You're not supposed to touch with your hands to try to get it off the Kavi wipes. And we couldn't figure out what to do. And so Sarah's husband was working from home that day, and she called him and said, can you go to Joann's and buy this and this and this? Because we were trying to figure out how to do this for this young man. So now we have our own method.
So these are 2 samples, and I'll pass them around. These are Laura's handprints. And the other is our other nurse practitioner. So this is one of the projects that we can do with families, especially if we do have people who are in the hospital. Children of certain ages aren't allowed in any still, so if they want to do kind of a hand-holding thing, we can do these. So this is one of the projects. We actually came up with 4 projects that we've put into action. So I'll pass one around each side here. The other 2 that I've brought tonight are pretty near and dear to my heart for different reasons. Wow. So I have a personal experience with these fingerprint necklaces. My aunt passed a number of years ago, and she was with the Palliative program at the University of Michigan. And when she passed, actually before she passed, she was able to share with us these necklaces she had made of her fingerprints in little gift bags. And she has 11 nieces and nephews and a number of brothers and sisters, and they made those for all of us. And so when I'm having a particularly poor day or I expect to have a challenging day, I wear it as kind of a talisman for the work that I do and for my strength. So in working with the grant money we received, we worked to create these fingerprint necklaces so that we could share them with our patients and create this linking object between patients and their family members.
The most we've done is 30.
The most we've done is 30. And it's just been an incredible thing to be able to share. Sometimes we've been able to do them with the patient's permission. Sometimes we've done them with the family's permission because the patient is failing that much. And to see the peace that it brings to family members, to have that part of them, is really an incredible feeling. And then the next one is one that we brought on at our hospital. We don't have as many services for children because we don't really have a pediatric ward. So we took this from the Child Life program. And what this is in recognizing that some of our patients have younger children, and we want to create this link between them and their children, we have matching teddy bears. And often the chaplain and I will be able to take the bears, and we take one for the patient and one for each child. And the chaplain will do a blessing if that's what the family wants. And we have the patient keep them in their bed to kind of show that bond. And then the patient has one, and the children have one. This was pretty incredible. I think the first ones that we did, I had a special relationship with that family. My daughter was close with one of the daughters of the patient, so I got to see how that played out. And I still hear tales of that bear being loved and held, even without her mother there. And the bear is pretty important there. We've used them in other ways too. We have a grandmother who had come in and was not able to see her grandchildren, felt very close to them. So we used that as a linking object between her and her grandchildren. And every time she has come back in and out of the hospital, we hear about how those are doing. So this has been another one that's really dear to my heart. And it's incredible to be able to give these to patients and their families to show that the bonds we have as people don't end with death, and that we can create those lasting pieces.
It's when we started with the bears, it's when the Delnor gift shop was closing. And so we actually used our own money and bought them out. So now our manager has given us money to buy bears. So this kind of sums up what the palliative team is, your quality of life team. So a lot of times you'll hear something like, she failed chemotherapy or he failed chemotherapy. So we look at it as not that they failed chemotherapy, but chemo failed her. She didn't progress, because they'll say, well, she progressed. The cancer progressed. No, the disease progressed. She never complained about the side effects. We never put that word complained in our charting. She reported the side effects. She didn't become palliative. She needed a new way of treating her whole being as she lived. And so that is palliative medicine. Okay. Any questions?
How do you get involved? Does somebody come to you or you?
So if somebody wanted to establish with the palliative medicine team, they would have their physician place a consults.
And that's both as an inpatient and as an outpatient. So if you're seeing your specialist out in the community, talking with them and seeing if they think that you'd be a good candidate, and then they would place a referral.
Or primary care.
Or primary
We get a lot of
care.
primary
We get
care
primary
consults
care,
too.
right.
Do the physicians have to be associated with Belmore, or could they be associated with other medical groups?
So other healthcare systems have palliative programs as well. So I don't know if there are any freestanding palliative groups besides those that are under the hospice agency. But typically every healthcare system, I know like, it used to be called DuPage Medical Group. It's called Dooley now. I know that they have a palliative team. Used to be called Advocate. It's called like Aurora Advocate now. Everybody used to be something else. I know that they have a palliative team. So they have there are other palliative. Actually, if you have an outside physician that's not associated with Northwestern, I mean, it doesn't have to be a Northwestern referral to us as well, too.
Your training, where do you
Oh.
use this or what, or-
So I was a nurse. I mean, I am a nurse. I'm always a nurse. And then I went to school and I became a nurse practitioner. So I'm a nurse practitioner. And then I did I'm actually in a doctorate program right now, and I'm doing, my project is on cancer pain. So, but I also have a certification. There's a specialty certification for advanced practice nurses.
I was thinking getting into psychology or something.
And our physicians are,
You probably introduce yourself.
oh.
No.
Oh, yeah, go ahead.
I'm Sarah. I'm the social worker with Palliative Medicine. I don't know if
Yeah.
I thought we said that, but I am a master's level trained social worker. I have, prior to working in palliative medicine, I worked in oncology. I've worked in home health and hospice, as well as some other community clinical programs. So that's how I've gotten here.
And so the physicians, they did their residency in internal med and family medicine, and then they did a 1-year palliative fellowship. So they're palliative trained as well. Yeah.
If someone's been going through chemo for 12 years,
Mhm.
and they maybe weren't aware of you,
Mhm.
is it at any point able to?
Any point at all. And so a patient, if somebody's been going through chemotherapy for a long period of time, it doesn't matter at what point they get involved with palliative. They don't need to be on with us in the beginning. I mean, 12 years ago when they were first diagnosed, it was probably, hey, let's fix this, right? That's what we also talk about, the definition of hope changes along the way. You know, there's always hope. It's just that the definition of hope changes. Something else that we like to talk about too, a lot of times you'll hear people say they equate these types of diseases to wars or battles and keep fighting, and which always bothers our team a little bit, because you you do keep fighting, but you change that fight for something different, right? You change that fight for quality of life, or you change that fight, and to me, that's just as honorable or valiant a fight. So,
I think sometimes why it bothers our team is because often if you're equating it with fighting, it's seen as a detriment of the person's will if the disease takes over and you stop fighting. And the reality is that these diseases are life-limiting and death is a part of life. So how do we create a time frame where it's the best quality of life and we can walk through those times with our patients?
yeah,
I wanted to comment on the thumbprints.
yes.
A number of funeral homes offer that same type of thing, where they will take a thumbprint of the deceased, and there'll be a piece of jewelry.
I did not know that.
And to see how meaningful that is for families to have that as a keepsake, or whether it's a necklace or a ring or something like that. The other thing I wanted just to mention is with the power of attorney for healthcare, that also gives that individual the ability to make funeral arrangements and disposition choices too. So as you choose that person, that's always something to consider as well.
That's true. So when you choose who you're going to choose, she wants me to repeat the question, I think. So when you choose who you want to be your healthcare power of attorney, make sure that part of the conversation is funeral arrangements and where you would want to go, what you would want done to your body. And what's most important about that form, that healthcare power of attorney form is, and I tell all my patients this, keep talking to that person. Keep talking to them. Keep telling them what you want. Because what you want one year may not be what you want another year. One more quick thing with that post form. If you don't have that in the state of Illinois, there's something called the Illinois Surrogacy Act. And so if you are a married couple, your spouse is automatically the surrogate. It's on the back of that.
So the Illinois Surrogacy Act is on the back of the post form. What that basically says is that if you have not designated a power of attorney, they will go through that list of people in that order to determine who would be the person to help make decisions for you.
Can someone overrule what you put? I'm afraid I know the answer to that.
Oh, can somebody overrule what you have put on your post form? So if you say on your post form you want to be a DNR and then your healthcare power of attorney comes in and you're not conscious anymore and can't make your decisions, they can.
People, you can always be involved if they're really facing the issue. Say, whoa, wait a minute, what do you mean that now? Go ahead, work on it, we can work something.
Oh, so you can always change those post forms. You can always change them. They're on a live document. You would do a new one. You can always, I always say with my post form, my husband's sitting over there because I had cookies, but I always say with that, because I struggle to figure out who to make my healthcare power of attorney. I love my husband. I've been married 35 years, but I kind of want my son, who's a surgeon, to be my power of attorney because he'll say, enough is enough. And so I know he loves me very much, but I want really medically sound decisions too for what I want. Mm-hmm. But no, those I've had patients that fill them out every time they come in. There's some people that have 5 or 6 post forms in there.
We always tease my mom. She would never sign one because she didn't trust us. She lived to be 96.
Good genes.
If someone's struggling with whether to stay in their home
Mm-hmm.
or move out, do you help in those situations when they maybe don't want to listen?
So the question is when someone's struggling, if they want to stay in their home or move out, maybe family feels that they're not safe in their home anymore, but they want to stay. Do we assist with that? We will have continuing conversations. We're a team that always shares our worries with people, but we're also a team that recognizes how important that independence is. And so while we can share our worries, we can't strong arm anybody into making that kind of a decision, but we can definitely discuss our worries and discuss why we think there would be benefits at a different level of care living wise. Part of my role on the team is knowing all those different levels of care and what they bring to people and how we can work within them. So in working with our team, sometimes in the hospital, we talk about that in terms of helping people actually make the transition. From the hospital, we have the case management team that assists with that. And then unfortunately from the community, it often comes in the way of guidance to have the family make those steps.
Is your involvement or care covered by insurance?
Is our involvement or care covered by insurance? Huh?
Depends on the policy, right?
That's what I learned today. It depends on the policy. Typically, we are covered by insurance like any other specialty. I ran into a Medicare Advantage plan today where we are not covered. So that might be the first time that has happened to us. But typically, we're covered by any other specialty. If you go see a cardiologist or an oncologist, we're going to be covered the same way.
We generally help to keep people out of the hospital too, so insurance companies kind of like that.
Any further questions?
Yeah, I was all looking forward to it.
I'm sure. Thank you so much for having us.
Cookies every day.
We were super excited to be included in a spot on our own and not palliative and hospice care because we are different. Thank you.
Thanks for that.
That's because there's a certain pastor who worked with the palliative care, not this palliative care team, but a few years back. That's why I understand it, because I saw the gift that it was for a family. So thank you for being here and for your work. So I hope a lot of people watch this as well out there in YouTube land. And again, thank you all to be here. Sure you don't have any more questions? We know where to find you. Yes. So thank you. I'll do a quick close in prayer, and then they'll ask all the questions not on tape. This is what usually happens. Every week that they're like, wait, now we can really talk. The secret conversations. The Lord be with you. Oh, God, you walk us through so many interesting things, and we learn so much, and you really care about our quality of life. And we're so thankful for Laura and Sarah and all the team of people that will help and encourage us to live life fully and abundantly. So keep watch over us as we go on our way, and help us to be faithful in all of our decisions. In Jesus' name, amen.